Hello, everybody, and welcome to the pre-show of the 2022 Push for Empowered Pregnancy Stillbirth Prevention Symposium. So we are very excited tonight to have a few special guests with us, including Dr. Harvey Kleiman and Dr. Heather Florescu. I guess let's start with some quick introductions, because we're assuming that probably everybody here has watched last year's symposium recording, but just in case they haven't, do you each want to introduce yourselves and what your talk was about?
Dr. Heather Florescu. I'm a private practice physician in Rochester, New York. I don't know if thrown is the right adjective, but I got a call to action in 2019 after attending the Star Legacy Foundation summit and realizing that it was a complete myth that stillbirth is not preventable. So I've been on a mission locally and hopefully nationally to try to prevent stillbirth. So about 3 years ago, I incorporated the UK and Star Legacy protocol into our practice, and I think it's been a really great success.
Thank you, Heather. And Harvey, will you remind us what your talk was about last year?
Sure, but that's inspirational. Let me just give a brief introduction about who I am. So I'm a physician scientist, MD, PhD at Yale University School of Medicine in the Department of Obstetrics, Gynecology, and Reproductive Sciences. And my specialties involve infertility, pregnancy complications, and sadly, stillbirths and miscarriages. My goal is to, just like Heather just said, to prevent stillbirth whenever possible. One of the main things I work on, I'll be talking about this tomorrow, and I talked about it last year, is a method. It's a very simple method called estimated placental volume measurement, or EPV for short. And basically, since the placenta supports the fetus, if it's too small, the fetus can die and we can have a stillbirth. So my goal is to have people incorporate that into clinical practice to try to prevent stillbirth whenever possible.
Thank you so much, Harvey. And so, okay. So let's just to like kind of lay the foundation of where we're at right now. So we have got here, this is at pushpregnancy.org /counter. It's also under here, stillbirth counter. So I have input here the date and time of our last symposium on May 22nd, 2021, starting at, oh, actually, I think it was 10 a.m. Let me fix that. Let's be accurate. So let's see how many, oh, wow. So according to our counter here, and this is using the CDC data, the average of the last 5 years, 22,750 babies have been born still in the US since we last gathered. That number is staggering. But I think probably the worst part about it is that we've got between 5,600 and 17,000 of those babies could potentially have been saved. Yeah, that's sickening. So this is why we're here. This is why we're gathering today. This is why we're doing the symposium again. This is why Push is doing everything that we're doing, because these babies should be here in their parents' arms. We know we can never prevent every stillbirth, but we feel that every baby, every parent that loses a child deserves to know that they and their providers did everything possible to give their baby the best possible chance. And unfortunately, probably 22,740 of these families can't say that today. So let's talk about it. Let's start with kind of bigger picture. In the last year, what has changed? What have you guys seen change in the medical landscape, in society, in awareness of stillbirth, if anything? And I'm going to stop sharing my screen so we could see you talk.
Heather, you please start.
Oh, okay. Oh, that's hard because it's hard to know what changes on a like small scale basis, but I think in the last year I've made some headway, maybe at my local hospital. I really noticed an improvement in that. I don't know if I had it last year totally in place, but my hospital I deliver at used to just, when patients had the complaint of decreased fetal movement, they would just come in for an NST, and if it was reactive, they'd be sent home. I don't know when I convinced them to change that. I can't remember dates, but now every patient who comes in with a concern for decreased fetal movement is seen by resident attending, and gets a full workup just like they would if they had a headache. I've been really pleased that when the residents call me, and maybe it's just because they're calling me, but they seem to naturally say, and the patient was reassured by this evaluation. So really kind of honing in on that important piece of the puzzle. So I would say that is improved.
That's
right.
great. That is, I mean,
Yeah, I think it's
that's huge.
I think it's a change. Unfortunately, it's a change because I'm standing there in the middle of what we call the fishbowl, annoying every single resident who will listen to me. And that's not going to really get beyond Rochester, New York. So that's why we need other stuff. One of the other hospitals locally, my favorite high risk OB, as I was saying, he has hired a loss mom to make her focus kind of care for people after loss, but also putting in all the prevention protocols that we've been using. So there's little changes, but locally I can speak most to it. So.
Well, that's awesome, Heather. I mean, and I think that really speaks to the power of what one person can do, because it really has just been kind of you standing there yelling from the rooftops, right, for the last couple of years. And I know you've been frustrated that it's taken some time for people to listen, but it sounds like they're starting to locally. And, if we can get one doctor to do that at every hospital, right? I mean, that's all we need. But it takes time, and we got to get the word out, right? Harvey, how about you? How about from your perspective?
So I think the biggest thing I've seen since our symposium we had last May is that, number one, PUSH was born, speaking of birth, on the symposium. And I think PUSH has had a tremendous impact. Some of the things that I've seen, for example, is that once a month we do a clubhouse event, the first Wednesday of every month at 8:30 p.m. Eastern time. And I'm part of that. And I think it's been a great opportunity for even some of my patients who have interacted with me before, and I've helped them, new people coming in, and the number of families and lost families who have contacted me in the last year has skyrocketed. So I think the first step, and I view this as a two-step process in terms of a loss. Obviously, it's the last thing that I want to see in any family is having a loss. And as I say often, I hope that you don't need me as a physician, because if you need me as a physician, it means that something bad has happened and you've had a loss in your life. But the reason that I'm so dedicated to working with these patients is that I think somebody needs to help them. Women feel so guilty about these losses. They think they did something wrong. And my first step, as I said, this is a two-component interaction with families and patients, is to help them understand why the loss occurred. That is really step one. I understand that bereavement is important, and I support any of those things that help people deal with the tragedy of loss. But being an MD, PhD scientist, I'm a much more practical person. And my view is that in order to even have closure and healing from that loss, and also to get the guilt away from the mother who feels that she's responsible, I want to show these families tangible evidence of why the loss occurred. And literally, there's nothing a woman can do. It's not zero, but virtually there's nothing a woman can do to cause a loss. So that's step one. And the reason that's so important is that it helps inform me, educating them about what they can and can't do to prevent a future stillbirth. We know that women who've had a stillbirth have an increased risk of a subsequent stillbirth. And it's bad enough to have a stillbirth. The last thing I want is it to happen again. So working with people like Heather is a pleasure for me, because she's been very responsive in dealing with this one particular issue, which is small placentas, which happens to be the number one cause of stillbirth. So when I diagnose the cause of a stillbirth being a small placenta, doctors like Heather Florescu are critical to help those patients in their subsequent pregnancies. They're very anxious. They're very worried about what might happen. And so having somebody to send those patients to in the Rochester area is really a pleasure for me. The second thing is then take all the knowledge we have about stillbirth and try to prevent them. And that's why my focus in terms of my research and clinical research is on estimated placental volume. So those are the two main things I've seen, and it's been a real tremendous increase in activity in terms of the patients that come to me. I'm very grateful to push for getting the word out. And tomorrow's symposium and the event in October in Washington will continue to help shed light on this. And I'll just do a shout out to the Shine law that basically is going to try to get teaching and education professionally to doctors to extend the kind of work that I do around the nation. So that's an important movement. So those are the things I've seen in the last year, which I think are great steps and contributions moving forward.
Thank you, Harvey, and thank you for calling out about the Shine for Autumn Act. For anybody who's not aware, that is a package of laws which has actually already passed in the House, and it has just been introduced into the Senate by Senators Cory Booker and Marco Rubio. So we're bringing the country together over stillbirth prevention, which is a wonderful and miraculous thing. But we need more co-sponsors, and we need votes, and we need to get this to pass if we want to lay the foundation here to start really making a difference in ending preventable stillbirths. So one thing that you can do as a family, as a supporter, as somebody who loves someone who lost a baby, and as a provider, is to go to stillbirthstories.com. And there is a really simple tool. It literally takes 2 minutes. You put in your name and address. It'll look up your who your representatives are, and we'll send them an email, which you can customize or not. And then if you wish, it also has steps to make it real easy to call your senators, which is even more effective, and also to tweet them. Apparently tweeting your senators is also effective. So we encourage you to take those steps. It really does make a big difference. And that is probably the highest priority thing we've got going on in the stillbirth prevention world at this exact moment, because we're hoping to get that passed in the next couple of weeks before all of the Congress people, retire for summer break. And as Harvey mentioned, the other big thing we've got coming up is the big push to end preventable stillbirths. So that is our 23,000 empty stroller march on Washington, and that's going to be on October 15th. It is totally free. There will be options to participate virtually or at satellite sites across the country. So please go to thebigpushmarch.org and RSVP there. Let us know if you're how you want to participate, because we're basically looking at where people are located to figure out where to put the satellite events and how many people we can actually get to DC with us. Did you guys see that the Shine for Autumn Act was in USA Today today? Debbie Hain and Marnie Smith from our team co-wrote an editorial to talk about why stillbirth prevention is so important. So we're super excited about that. But let's talk about last year's symposium again. And Harvey, there have been some big developments in the EPV world. Would you like to share a little bit about the progress that's been made there in terms of getting EPV on ACOG's radar, in terms of influential people at SMFM starting to test it out?
Well, actually, I think you're the best person to share about ACOG since you have interacted with them. So I'm going to turn that back to you, if you don't mind. But thank you for, I am here spiritually behind anything to get EPV on the map. I will just say that I'm involved with an international EPV working group, and we just met this morning. We meet about once a month. We have another EPV working group that Ann O'Neill, who is the person who started measuretheplacenta.org, is involved with me. I'm going to be in Rochester working with, I think, Dr. Heather Forestew's favorite MFM, Dan Grace, I believe, right? And he luckily has he's basically said, listen, I'm intrigued enough about this, so why don't we start doing it on every patient we see? So I'm going up on June 17th to spend the whole day with them to do a training session. And I think that's an exciting thing. So whenever possible, we're always trying to get EPV on a one-to-one basis for particular patients used. I'm always available to teach how to do it via Zoom to anybody who needs to. So we're constantly doing lots of things, but we have a long way to go in terms of changing practice. But I want to turn it back to you, Samantha. Why don't you talk about your interactions with ACOG? I think you're the best person for that.
Yeah, so we have had a really successful campaign. We started back in, I think it was November. And again, it's the push team working very closely with the Measure the Placenta team of Ann O'Neill is we call her the general. She's been leading the charge over there. And it's called hashtag Hey ACOG Measure the Placenta. So if you go check that out on any social media platform, you'll kind of see what we're doing. But basically, we've got families signed up, and you can be one of them. There's a link in the Measure the Placenta social media pages to send letters to leaders at ACOG pretty much every day from now through the end of the year, or however long it takes. I think so far, last count, I think we sent around 26 or 2,700 letters. And each of these are being printed out with a baby's story, in many cases, a baby who was lost to a small placenta. And we are asking for a consistent set of things for ACOG support. Number one, to make stillbirth prevention in general a priority in this country, has been done in other countries where they're seeing huge improvements very, very quickly. Number two, to look at EPV as a tool to potentially prevent, up to 4,000 small placenta stillbirths a year. To us, this seems like really low-hanging fruits because, again, these are babies that are at the very end of pregnancy, typically. So, it's not like a high-risk situation where you're delivering a baby, at 34 weeks or something. These are full-term babies. EPV is completely non-invasive. It takes 30 seconds on any standard ultrasound. There's really no risk associated with it. It's just another piece of information to help providers risk stratify, to understand the different risks that a patient is facing and determine, the best possible time for delivery. So we've been asking them to please consider EPV in general for all pregnancies, because that's eventually where we want to get it to, though we understand that, research is important and you don't want to, push things out on a large scale too quickly, but that's another area that we're investing in and you will hear more about tomorrow. And we are asking them that in the meantime, at least for families who've had a previous small placenta stillbirth, give providers the okay to do this, because we are hearing daily, unfortunately, from parents who are going to the providers and asking them, please measure my placenta. My last baby died from having a too small placenta to support them at the end of pregnancy, and I want to make sure this doesn't happen again. And far too often, we're still hearing from providers, well, I can't do that till ACOG tells me I can. So we've gone directly to ACOG and said, please tell them they can, that there's no reason not to try this. It certainly is not telling you that this is what you have, that you have to deliver if you notice small placenta. It's just another piece of the puzzle to say, hey, this baby's potentially vulnerable. Let's keep a closer eye on them. Yeah, and it's been effective. We have had, Ann and I have had 2 meetings now with the VP of clinical practice at ACOG. He leads the committee that sets the prenatal care guidelines for all pregnancies in the US. So we are, and they've been receptive. They've also been really interested to hear that a lot of patients are not getting fetal movement education, or are still hearing fetal movement myths, even from their providers. And they were very, very concerned about that, because it is not in line with the guidelines that they have set forth. And so
What guidelines?
Well, the guidelines they think that they've set forth. But yes, and they want to fix that. So I mean, already we're making strides, we're making progress. But yeah, speaking of fetal movement, Heather, can you tell us how it has gone? I mean, that was one thing that was a big part of your presentation last year, right? A big change was that you started doing a very standard fetal movement education talk with your patients at the same point in every pregnancy, right? And a lot of times what we hear from providers is, oh, I don't want to talk to my patients about this because it's just going to scare them. It's going to make them anxious. Kid counting has not been shown to be effective. What do you say to those kinds of pushback, and what have you actually seen in your practice and in your patient's response to this change?
Yes, I would say, 99.9% of the time, there's no increased anxiety. There are definitely patients who will be anxious no matter what we say to them. So you always have that kind of aspect of things. And I kind of know my patients well enough that I know the ones who are going to freak out. And I kind of have a way of saying to them first, talking about this doesn't make it more likely to happen, it makes it less likely to happen. And trying to just, there's patients who I can hand it to and they're like, this is great, I love it, and I know they're not going to get anxious. And then there are people you can tell them like they're nervous Nellies, and I have one patient who's incredibly high risk, doesn't want to believe she's high risk, so hearing it is more kind of affirmation to her. And it's kind of just, I think it's always about taking the time and saying, this is what I give everybody. This is not related to you. This is every single pregnant patient. And really just taking the time. I think the reason why studies have not shown improved outcomes like we'd like them to see is because it is not being done in a thoughtful enough manner. And I think that's really the biggest key is it's taking the 2 to 3 minutes it takes at one really prenatal appointment. I do try to readdress it as we get, especially a term. I go over the fetal movement myths with every pregnant patient I see a term. I remind them that they're never bothering us. I remind them about the card that they have in their fridge and kind of those kind of things. But it really, I think it's been a very successful thing. I think it's empowered our patients to advocate for themselves for other concerns, not just fetal movement. A little aside is I was at ACOG a few weeks ago, and I did the best I could to draw in every single solitary person who made any eye contact with me. And it was really interesting, the providers who were very interested in having conversations with us, and then the providers where I had to really convince them that they weren't doing as well as they thought they were. And I think I made a couple of those people, quite kind of a little surprised that I was that bold, but I said, with all due respect, you're not doing it this way. And, encourage them to give cards and knowledge. So.
Thank you, Heather. And Harvey, actually, we do have one more specific follow-up question from the content you presented last year, if you would like to answer it. It is, at one point, Harvey said, if you drink enough water for your urine to be clear all day long, it will increase placental perfusion. Is there anything else that we can do to increase placental perfusion?
Not really. I mean, yeah, obviously maternal blood, let me give an analogy. You can think of the placenta as the root system of the fetus, and imagine the roots in a bucket of water and the plant above is, the umbilical cord in the fetus. Basically, the only thing we can do is get water to circulate into that bucket, right? And the only place that can come from is the mother's blood. So for her to be what we call in medicine well hydrated, right, to have enough water on board so she doesn't become dehydrated, is about the only thing that you can do. Now, obviously, eating well and following good nutrition is always a good thing. It's interesting, the state of pregnancy is always leaning towards diabetes. Now, what is diabetes? Practically, it's more sugar in the blood of the woman. And it's true that we don't like to see those levels go too high, but in a way, that's the placenta making the woman put more nutrients into her blood. So the placenta gets more nutrients, right? So if there's a small placenta, I would say anything that can get more nutrients to that placenta, whether it's fluid and what she's eating, is a good thing. Obviously, with the direction of her OB and maternal fetal medicine specialist to not do anything that's dangerous to her, but that's about it in terms of what she can do. Heather, what are your thoughts on that? What do you say to your patients about keeping their baby's placenta well hydrated? Do you have any thoughts on that?
I don't know if I specifically, I definitely, obviously we talk about the sleep, falling asleep on their side to keep it well hydrated at night. I think it's really just encouraging healthy eating and exercise, drinking lots of fluids, trying to notice when people are not drinking lots of fluids. I love when my medical assistant will say, their urine was really dark, that kind of stuff, because that's one of those things you can use a lot to encourage future, further hydration and stuff like that. So
that's why I like the simple rule. Your urine should be clear. If it's yellow, if the toilet looks yellow when you're done peeing in it, you are not drinking enough fluid, period. It's just very simple rule of thumb. So let that be the starting point. I think we certainly want to eliminate anybody with dark urine. That is quite dangerous for a fetus to have a woman be dehydrated. So we need to make sure she drinks more fluid under those conditions.
And I love that it really is just such a simple, clear, easy rule of thumb. I feel like we got to make some social media posts about that, right?
Yes, I think that'd be
some kind of catchy slogan about it.
Samantha, you're the best at that. Go for it.
I'm putting it out to the push team. Guys, start thinking of a catchy slogan
about urine. Yeah.
But yeah, no, I think, and that's really interesting because we actually, so I don't know if you guys saw on the roster for tomorrow, we have Skye Wheeler speaking. She's a senior researcher at Human Rights Watch. And she also chairs the March of Dimes Mom and Baby Action Network Environmental Justice Group. And she is doing a talk about climate change and environmental factors and how they affect birth outcomes, including stillbirth. And, that's one of the biggest concerns is heat as the planet is getting warmer. And especially, people with fewer resources are, more likely to be in positions where they cannot get cool, they cannot get enough water to stay hydrated. That's going to have a serious impact on birth outcomes. And it's something I think we all need to be aware of. And again, that's such a really simple litmus test, right? To just make sure that you're staying as hydrated as you need to be.
I see a good question here in the chat that I'm going to direct to Heather. I hate to do that, but here's a question regarding what to do when your provider will not listen to your concern about fetal movement. And they say to you, you're just fine. Don't worry about it. What would your advice be to a new mom if their concerns about fetal movement are being ignored, basically?
Yeah, I think there's a couple things. I think the same way that I will say to a team when I'm taking care of a patient, I feel unsafe. I feel worried. So using kind of classic concern saying, and I think the best advocates, and one of the things that when I hear my patients say, I get that you're telling me the NST is fine. I get you're telling me the ultrasound is fine, but I'm still worried. And I think it's just saying that may start to trigger. I certainly think if somebody's past 39 weeks and they're coming with decreased fetal movement and they're not reassured by the evaluation, because many people are, but they're not reassured by whatever the provider has already done, saying, I'm past 39 weeks. I am not comfortable being pregnant anymore. Can we set up an induction? What can we do? Unfortunately, with at least in our, a lot of hospitals, or nursing is an issue. There's only so much inductions you can bring in, stuff like that. But at least giving somebody we're going to end your pregnancy as soon as possible and put you on for an induction, even though the fluid is normal and the growth is normal. The EPV probably isn't. But we haven't gotten that yet as a indication for induction. I hope we get there. But, I have had some patients where they're concerned about recurrent decreased fetal movement. They're 39 plus weeks. And I do have that small EPV, which I can't use yet, but I do this patient's very worried about her baby. We're going to try to deliver her type thing. So I just delivered a very healthy baby with recurrent decreased fetal movement, and her placenta, was 0.2 percentile. Yep. And had and I think the thing that's really fascinating about it is her baby was perfectly well behaved the whole labor. So the act that fetal monitoring actually means anything, there was no drama. It was the easiest induction in the world. And one of the nurses said to me, because she was bumped for a day, this patient, and she said to me when she said that she could come in, the patient started sobbing. And she said, oh, she's going to be challenging when she get here. I was like, nope, she's sobbing with relief that you bring her in. As soon as we get her on the monitor, she knows she's safely in the hospital. She's going to be absolutely fine. And I was completely correct. Oh. It was just, she needed to know that she was having her baby, almost like somebody who'd had a prior stillbirth. So
I so connect with that feeling. I just remember the huge weight off my shoulders when I finally got to check into the hospital and be on constant monitoring in my subsequent pregnancies. I mean, that anxiety it's unbearable, especially those last few weeks.
Yeah.
And it is just such a relief to know that there's somebody else watching, because you feel like the only, like you're the only thing standing between your child and certain death when you're in a pregnancy
Yeah.
for loss, especially those last few weeks. So
Well, and that's what I would say for the small EPV patients with recurrent decreased fetal movement. They are like somebody who's had a prior stillbirth. Their instinct, some of these patients I've had, is so incredibly strong
that's great.
compared to the patients who I've had a couple concerns, but I'm getting a normal EPV and everything looks good. They're different. And I think that's why Harvey didn't say that one of the things that my favorite MFM is doing, I don't want to overly use, plug his name, but he is doing prospective study. And while prospective studies are hard sometimes because you wish you could just implement it without it, the fact that he is collecting prospective data that's hopefully going to show the effects of a small EPV is really what's going to make ACOG listen. And so I'm really excited to see what his results show.
I'm really, really excited to see that too. I want to give a
too.
shout out to Shawnee. Hey, Shawnee, thanks for joining us.
There are a bunch of questions I'd like to,
Yeah,
if that's
go.
okay with you,
Take some
Samantha. There's a great question here from Meredith McLeod Cobb. I hope she's okay with me shouting out her name. She asks, can you both talk about, that's both you and I, Heather, about low dose aspirin? Does it decrease the risk? Let me start with it from a placental point of view. So aspirin, amazingly, 81 milligrams a day has been shown to significantly decrease the risk for preeclampsia. What is preeclampsia? Preeclampsia is a condition where there is not enough maternal blood flow to the placenta. The placenta is not happy with that, and it basically makes the mother hypertensive in response to that decreased perfusion. The placenta is made genetically by the dad, and his message is, I want the biggest baby possible. And if there isn't enough blood flow to the placenta, that placenta will make the mother hypertensive. So it's been shown to be effective with that. Now, why does aspirin do that? Well, it inhibits platelets. Platelets aggregate together, can cause little microscopic clots. And so a low dose of aspirin is one of the things that in general, unless there's some contraindication, I think is a reasonable thing to add if there are concerns about maternal blood perfusion into the placenta. So, and every time I see a patient that's had a small placenta, as one of my recommendations to their doctors for future pregnancies is, as long as there's no contraindication, to start the 81 milligrams, which is called baby aspirin, starting about 10 to 12 weeks. It really has very little potential for harm and has the potential to allow for increased perfusion, in addition to the things we talked about before, hydration and things like that. Heather, I'm curious what your thoughts are about 81 milligrams baby aspirin for these patients.
So SMFM actually came out with, probably about 2 or 3 weeks ago now, we're doing 2 baby aspirin. So we've now increased it. They found more robust results in terms of preeclampsia. I was really excited about this because when you look at the studies on stillbirth and perinatal mortality, all those studies were over 81 milligrams. Most of them were in like the hundreds range. So I've been recommending doubling it for a while in my prior stillbirth patients, and now everybody's getting it. So I honestly want aspirin in the prenatal vitamins, or I want to be for everybody. I really think, I mean, and at this point, honestly, there's fewer patients who it's not indicated. So then it's really, I mean, we're giving it to all of our COVID positive patients. We're giving it to everybody who's over a certain age. We're giving it to twins. So the risk that, we do it all the time. I see somebody saying, does it cause harm sooner than 10 weeks? Most of us start around 14 weeks for the preeclampsia prevention. And definitely if people are on it before because they did like IVF or something, then we certainly say it's fine to continue. But if they have like what's called a subchorionic hematoma, just to not thin out that hematoma more, we'll say wait until that resolves. So kind of going a little bit further out.
Yeah, that was my next question for you was, is there any downside to baby aspirin in
I
pregnancy?
really don't think so. I really don't think so. I think I am not the only OBGYN who really just thinks everybody should be getting that. Oh, and I see a nice vaccine question. Yes, get the vaccine. Any pregnant women out there, the COVID vaccine has really been shown to be very safe. I have, knock on my woody head, not had a patient who is vaccinated and boosted who gets COVID who has had an adverse outcome. I have seen many, many adverse outcomes from pregnant women getting COVID who are not vaccinated. So please, please, please get vaccinated. We are seeing really scary things happen to moms, mostly like preeclampsia is the most obvious one. Women presenting unvaccinated with COVID and then are diagnosed with preeclampsia. And sometimes that's 39 weeks. Great, we can deliver the baby, but I've had 33, 34, numerous patients with this. So please, please, please trust your doctors. We're almost universally recommending it for, for pregnant women. ACOG strongly supports it. And so.
And ideally get vaccinated before you get pregnant. And I will say.
Yeah. So, but I saw a question about the second booster, and I don't think ACOG has officially said that yet. There is a really great study that showed out that if you're going to get the second booster or any booster, and it's possible in your community based on the risk to not immediately get it because you don't want to get sick, getting in the third trimester provides the best immunity for your baby. So it may be worth holding on a second booster if you're already fully boosted. Because I haven't personally seen, we're seeing really good outcomes to get it in that closer to delivery stage. So your baby's born with really good immunity.
I'll just add that sadly, I've had multiple cases of stillbirth just due to COVID, right? A woman gets it, she's not vaccinated, she gets it, it has a cold, but her baby dies because it's not common, but this virus can attack the placenta. And when it does that, that's the end of the pregnancy. So there's no question that if you can get vaccinated before you get pregnant, that is the route you should take. You should definitely be vaccinated before you get pregnant.
Yeah, can you guys just want to get a very clear answer here, because I feel like a lot of people have been misinterpreting that advice. Like I've heard people say, oh, well, they said don't get it in your first trimester, so that must mean it's not safe. But is the reason they're saying it's better to get it before you're pregnant or in your third trimester because it's more effective then, not because there's any safety issue? Can you guys just be very clear about that?
Yeah, there's currently no safety issues for any gestational age for getting the COVID vaccine. The argument to do it before pregnancy is then you're protected before pregnancy. And we don't know the effects of COVID on the first trimester. One of the things I point out to people is to be able to prove an anomaly, for example, would happen takes many, many years. So we really don't know that impact. And I do have patients who still choose to wait through the first trimester for the vaccine. So that's why if you can get it before, it's the best. Because, if somebody says, I'm not comfortable getting it during organogenesis, it's hard to, know exactly what to do in those states. So usually I'm like, wear a mask really well and then come back as soon as you're in the second trimester and get vaccinated. So,
well, I would just jump in and say, this is why I'm very strong on being vaccinated before you get pregnant, right? Yeah. Hopefully this won't even be an issue, especially given how prevalent vaccines are now. I would just say this, the only thing about the first trimester to point out, and this is a paper we published at Yale about 6 to 9 months ago now, is that the placenta has much higher level of receptors for the virus in the first trimester than it does at any other time. So it is uniquely more susceptible to a COVID infection in the first trimester. It's not equal. It actually starts very high and drops down to almost no susceptibility in the third trimester. So I think that's why there's some thoughts about the first trimester being a little risky. But again, the easiest thing is just make sure you're vaccinated before you get pregnant. Then you don't have to worry about this issue.
Thank you for clarifying. And Harvey, one more question for you from the chat I see here. Meredith asking again, can you talk about the studies about placentitis from COVID? Is this just destiny if you have COVID while pregnant?
One of the reactions that happens in pregnancy when a woman gets COVID is that there are two things that go wrong with the placenta. Number one, the virus literally goes into the cells of the placenta and kills them. Two, the mother's immune system, in an attempt to try to protect the placenta, sends in particular cells called monocytes into the space around the fingers, the root system of the placenta. And in the beginning of COVID, I had a lot of cases sent to me where people thought it was an entity called chronic histiocytic intervillositis. That's that placentitis thing. And they can look similar. And in fact, sometimes I can't tell the difference. The only way to prove it is to actually do what's called immunohistochemistry to stain the placenta. This is, of course, the fact that I'm staining the placenta means that there's been a loss, right? I mean, this has already happened. This is sort of a trying to figure out what happened in the pregnancy situation. Ideally, we're going to try to prevent this from ever happening by being vaccinated first, to go back to that. But if you're not and you get COVID and there's a loss, what we're going to look at is to prove that the COVID did it, is to actually find evidence of the virus in the placental cells. That's how we do it. But there is some overlap under the microscope between this placentitis and the COVID reaction.
Thank you, Harvey, for clarifying that.
There was a question that came up before that I would love to hear Heather's thoughts, and I think we need to talk about it. There's sort of overlap, if I can paraphrase them, sort of the push, what's it called? Natural birth influencers.
I saw those too. I was interested.
Right.
Yes.
That's a good question.
And
let's go there.
I think we need to talk. I will just say one thing. Now, I'm not a delivering OB, so I turn to Heather for these practical issues. But when I was a medical student, one of the OBs that taught me when I did my rotation said something that has never left me for the 40 years since he said it to me, and that is, you can never argue with a healthy baby, right? So to me, the bottom line is having a healthy baby, not the sort of preconceived notions of what you think a delivery should look like or where it should happen or whatever else. This is not a party, right? This is bringing a life into the world. And so my bottom line, and Heather, please elaborate or comment on it, is we should do, and you should want as a mother, what's done is best for that baby's survival and getting delivered in a healthy way, in addition to having the mother be healthy. But please, I'm going to turn it to you, Heather, to amplify that.
Yeah, and I know, I'm sure this is a trigger for many people who are listening in now, is a lot of people in the low intervention natural birth community find it very insulting when we as providers say all that matters is healthy mom, healthy baby. To them, that is our excuse for medicalizing their birth. That being said, there are many things we do in birth that lead to this culture. And I want to be very clear about that. We do things that are not evidence-based, that are provider convenience-based, that are not patient-centered. And I think we need to improve the patient-centered care. So, for example, where there is no evidence that the aggressive massage that people do before the placenta is out limits postpartum hemorrhage. There's great evidence after the placenta is out. So when we do that fundal massage after placenta, evidence-based. Doing this before, that is not evidence-based. But almost every provider, baby comes out and they don't even let the mom enjoy the baby before they're mashing on her uterus to try to get the placenta out.
So unpleasant.
Yes. What did you say? Without
So
consenting,
unpleasant.
without explaining why, taking away from them holding their baby. That's what creates this culture. And I have actually been following quite a bit evidence-based birth, which is, I think, a really good resource for providers to learn where are these patients coming from. Because I don't think it's always coming from naivete. I think a lot of times it's coming from, I felt accosted by my providers. The control wasn't because they didn't understand that sometimes there isn't healthy mom and baby, but because they felt unheard. And that's what we talk about all the time here, right? Is empowering women. And these pregnant patients did not feel empowered during their birth. They felt like they were just lying there. And if anybody knows the evidence-based birth people, I would love to do a podcast about that on their show, because I think reaching these women and saying, hey, I hear you. This is, I get very frustrated when I see people getting over medicalized in their births. But there are things that we can do to help have a healthy mom, healthy baby, such as trust the doctor when we say it's time to induce, when we're using evidence-based things. When your blood pressure is 160 on 100, refusing induction is not the safe choice. So
yeah, there was this particularly infuriating Instagram video that going around on our push chat today. That was a natural birth influencer selling birth courses, of course, talking about how, when she was getting ready for her birth, she asked all of her friends, like, how did your births go? Tell me your stories. And they all, ended up going overdue, being forced to get inductions, which, caused the cascade of interventions, blah, blah, blah. And this was the real kicker for us. And they said, then for all 5 of my friends, it ended up in the worst possible outcome, an emergency C-section.
Yeah.
And when you're a mom who's delivered a baby who's no
Mhm.
longer breathing, I mean, that is not the worst outcome. Like, what
Yeah.
do you think these people really just honestly don't know that this is still happening?
I think that's part of it. I think that, so part of my concern is that stillbirth happens to these women too. And I can't tell you how many of my lost moms said, before I lost my baby, I was birth plan all the way. And that is why I want to talk to these group of women and why I want to reach them, because this can happen to them too. And as I said, I think the vast majority of these women and men are coming from it as they have been medicalized. And yes, there are many things we do that are very evidence-based and very important for support and health. But one of my biggest pet peeves is after the baby's out, when whoever's assisting me goes to look right away to see if the woman needs stitches. And I'm like, it doesn't become a worse tear because you give them 5-10 minutes. So people feel, especially if they're scared of healthcare providers, that this is where that's all coming from, is these quote unquote horror stories. And I think if we work at push to try to reach these pregnant people and say, there are things that we do that aren't perfect, but when we say your placenta is small, we think you should have a baby. Your baby's not growing, we think you should have a baby. Whatever your water is broken, we should induce you to have a healthy baby. That is totally evidence-based. And I think we have to, as providers, be honest about, here's the really strong science that is evidence-based, but saying it wasn't evidence-based when we accosted you as the baby's out to try to get your placenta out. And when we become truthful about what we do just because we do it, and truthful about what we do because it's evidence-based, then we gain the trust of people who are wary of birth, and we bring more births into the hospital where perinatal death is less, and we bring more trust. So I've learned a long time ago in my career, shutting myself out to people who feel different than me. And yes, selling it as a romantic notion. I will tell you, the most beautiful births I have are the people who have no plans. And I try very hard to tell my patients that going in with a que sera, trusting us. But I say that because I come from a practice where my partners all do the nice, kind stuff. They provide hands-on care. They're not doing those things. And I think it allows me to say, that's not what you get at my practice, but that's not true everywhere. And, you get a provider who comes in 2 seconds before the baby comes out, doesn't let you enjoy the baby, starts massaging your uterus. And it creates these seeds of, could I have gotten better care? And I think we need to all, as doctors, provide the best birth experience possible, because then people won't be fearful of our interventions and the things we recommend.
I think those are all great points, Heather.
Can I change the subject just slightly to back? There seems to be a pending question to go back to COVID for a minute. Let me try to address that. So the question is this destiny if you have COVID while you're pregnant that you'll have this bad outcome? Well, the good news is that it's actually rare to have a bad outcome if you get COVID during your pregnancy. In the studies that we did at Yale, and many other people have published this, it's less than 5%. Columbia, I know, university, they have it because that was the epicenter of COVID, just to remind yourself about back in March and April and May of 2020, they had the most number there. And they had, no maternal deaths, number one, and they had very few fetal losses, and wasn't zero, but it's certainly less than 5%. So I don't want women to feel that if they do get COVID during their pregnancy, that it's automatically going to be the end of the pregnancy. That's a rarity. Certainly getting it means that you should, do all the things we've said, empower yourself to be followed. If you feel decreased fetal movement or anything that concerns you, get yourself to the hospital. Don't even call anybody. Just go to labor and delivery, said, I had COVID. I don't feel my baby moving as much. I need to be checked out.
That's great. And does that hold true even for people who had, mild or asymptomatic cases of COVID?
Yeah. So the ACOG studies show the more severe the mother gets, the more severe the complications for baby. So they've had some pretty good studies that mild, which is why I think the vaccine's so effective, right? Because you're much more likely to have a mild infection. So is it rare? Yes. But I never did a C-section peri-mortem in an ICU my entire residency. All the residents have done several. So ICU deliveries were once every 5-year thing. And now my residents can tell me multiple stories about doing it. So while it is rare when you take a big hospital that does a lot of the tertiary care, they're certainly seeing it. And it's just a shame now that it probably can be prevented. So
Harvey, what do you say to someone who says that the placenta does not age and calcification of the placenta is not a reason to get induced if you are overdue?
So you mean in terms of being post dates after 40 weeks of gestation?
Yes.
Yeah. So there's been a lot of work on the placenta, the concept that it's aging. Let me pull back a little bit. Here's something we don't understand, which seems kind of crazy. We do not understand what actually triggers labor and delivery. What is it in our pregnancy, our species, that does that? We think it relates to progesterone. There are other animal studies that have a better handle on it, but literally to this moment, we don't have a good idea. So given that, we're doing the best we can. I think when I was a medical student, and that's a long time ago in the 70s, there are women who are delivering at 43 and 44 weeks. We just do not do that anymore because the chance of stillbirth goes up very high at that point. But I'll let Heather jump in after I'm done. I would just say from a placental point of view, it does continue to grow up until the time of delivery. It doesn't really age and die. That's not a fact about the placenta. And it's extremely resilient in terms of compensating. But the problem gets with the placenta, like any organ, the kidney or the lung in our body, you get to a point where the placenta cannot compensate enough, especially if you have a very large fetus and a very small placenta. That's a very bad combination. And that is why we're pushing on EPV so much, because we, as you said before, we want that just to be one other tool in the toolbox of data that an OB or an MFM uses to help make a decision about when to deliver a woman, right? That's really what we're trying to do. We need to collect data, make the most intelligent decision we can. So we cannot a priori simply say, I looked at the placenta, it looks this way, we should deliver. It's part of the equation to look at all this information. Heather, why don't you, chime in and give the group your thoughts on these issues too, please.
Well, I think the idea of the aging placenta has been there for a while. For a while we were grading the placenta, right, on ultrasound, things like that. And then they found that wasn't really making any changes. I think the thought is that the NST is going to show the aging placenta, that when you have a placenta that's about to give up, you're going to get recurrent late D cells, which certainly recurrent late D cells is a sign of things. But I think that is not, as I said in kind of my talk that I give, what does a baby look like right before it's going to die in utero? What does that NST look like? Do we really have any idea? And we don't, right? Because we don't watch as that is happening. So there is really no way of knowing when that gas tank is almost out what the baby's going to look like. So this notion that decreased fetal movement, you present and you don't have absent variability or repetitive lates, then your baby's totally fine, because it is just so antiquated. And we need to move away from that, especially in the setting of a mother who is not reassured by the evaluation we're doing. So
I feel I need to jump in and emphasize what you just said, Heather, so much. Number one, I myself, as you probably do, have so many patients who just before their stillbirth had normal non-stress tests. So just that alone proves to me it's a completely ineffective test. That's number one. But I want to give a deeper level to this. Electronic fetal monitoring was created at Yale University. It was invented at Yale University by Ed Hahn in the late 50s. And their idea, the reason for doing it was that, imagine their world, no ultrasound, nothing. They would simply have an extremely damaged baby, of cerebral palsy be born, and they had no idea, no warning that anything was going wrong. And so they were desperate to get something to, quote unquote, look inside the uterus. And that's why Ed Hahn invented electronic fetal monitoring. I had lunch with him when he was in his 90s, about a year before he died. And he told me that electronic fetal monitoring is the worst thing that he'd ever done, that it was a failure, and it never achieved the goal that he had in mind to look inside the uterus. And you've said it, I've said it, and I just think that I'm so sad when I see cases of stillbirth where just before they had a normal NST, and that was the reassurance enough to go home, and then when they came back, they had lost their baby. I think that's really terrible. Obviously, the NST does not work. I'm just going to categorically say that. And we need to have new tools, including estimated placental volume, to prevent these stillbirths. That's what I'm going to circle it back to the beginning. When you showed that clock, that's our goal, to prevent stillbirth. One of the things is not to depend on NST, because that clearly is not preventing stillbirth.
Thank you, Harvey. Heather, was there anything you wanted to add?
I see Anna's question, about,
we have one more question here that I think is that is really interesting. Oh wait, were you thinking the cord compression, or are you thinking
well, I was thinking that I saw a couple of things in there go by.
That's what I was gonna
there's a second trimester. What can we do in the second trimester? And one thing
Heather, we lost you. You've disappeared.
I don't know where it went. Can you hear me though? Okay. Okay.
Floating head.
So, one of the things that second trimester I'm a big proponent of is that first trimester screen. If you're over 35, get your first trimester NT screen, get your, NIPT. Now, one thing that I think reason why I think that's really important is sometimes we can unfortunately see things that may indicate future, because we know second trimester stillbirth is more associated with anomalies, chromosomal issues, things like that. So that's one part. Second trimester loss prevention is harder, even at viability, because in order to deliver an extremely premature baby, you unfortunately have to have an overwhelming amount of evidence that that baby is headed to stillbirth. And that can sometimes be hard to obtain. So I think that's, as much as I think we all want to tackle that 28 to 32-ish week, stillbirth, you have to be, unfortunately, you come in at 38 weeks with a terrible tracing or a really small baby. It's an easy thing to do. You have to make sure before you do an extremely premature delivery, I'm back, or I'm done, that made a difference. In terms of Anna's question about the cord compression, that is such a hard one for me. And I think finding true knots would be a wonderful thing to find. Assessing the coiling of the cord, because if you saw cord abnormalities, you could follow that pregnancy more closely. Cord around the neck is a hard one because we really don't know how much of an impact that has. So I think anything we can do to enhance finding true knots, which are associated with increased risk of stillbirth. And we always assess where the cord comes into the placenta. So that's an important part of the evaluation. So I don't know what to do about this. So yeah.
Thank you, Heather. And, these questions that are coming through the chat are really excellent. And I'm very excited because we actually have speakers tomorrow that are speaking about several of things that we've touched on tonight. Harvey, you mentioned earlier, we don't know what causes birth. We have Dr. Kristen Myers. She's a mechanical engineer from Columbia, and she works with our friends at the Iris Fund to try to figure out exactly that question. What causes the body to go into labor? because we do not know the answer to that question. The question of what can you do in the first and second trimester to try to prevent losses either then or later in pregnancy. I'm thinking of things like getting a cervical screening around 16 to 18 weeks to make sure that you're not, at risk of incompetent cervix, or I prefer to call it early cervical dilation. Getting a CMV screening, so you know your status throughout the pregnancy, because if you get CMV for the first time while you are pregnant, depending on when that happens, it could put your baby at risk. We're working very closely with National CMV Foundation, and we've got Kalia, their executive director, is going to be on our Stillbirth survivors, what I wish I'd known panel, as well as our friend Kaylee, every mama's heart, is going to be there and talking about her IC experience. Cord imaging, we've got Dr. Ilan Timur from NYU Langone coming to talk about how you can image the full umbilical cord. This is something that a lot of even MFMs don't realize is possible to do if you've been trained to do it. And he's done it for several people on our team. So he's coming to show us how. So we've got a lot of really, really interesting content coming for everybody tomorrow. So we're really excited to share that with all of you. Dr. Harvey will be speaking about EPV, some more details to show us how simple and straightforward it really is to do. And Dr. Heather will hopefully be joining us for our Empowered Pregnancy chat. Heather, you are on call tomorrow, right? So if she's not delivering a baby, she's going to try to join us for that one. But
I may disappear for a different reason then.
For a different reason. Oh my God. So
remind everybody, Samantha, what time we start tomorrow morning.
Oh, thank you, Harvey. Yes, we're going to start at 10 a.m. sharp Eastern tomorrow morning. And we will go through about 3 p.m. With a few breaks in there, short breaks. So make sure you got your protein shakes or whatever you need to power through. But of course, it will be recorded. Our session tonight is recorded. I know a bunch of people joined a little bit late. There were some questions asked in the chat that we had discussed earlier, for example, about the COVID vaccine and when is the best time to get that around your pregnancy. We had a long discussion about that. So we will put this recording up in the Whova app and on YouTube, probably not tonight, but in the next few days. So you can always go back and watch and get any questions that you missed. And also don't forget to join us after you have a little bit of a longer break after the symposium ends tomorrow at 4 p.m. We're going to be getting together on Clubhouse. That's the audio only app where we can all talk and talk about what we learned, what questions we have, where we want to go from here, and do a recap. And hopefully some of our speakers will be able to join us. Definitely several members of the PUSH team will be there. So we hope you guys can make it to that as well. Harvey, Heather, any last words before we sign off tonight?
No, I think I'm just so sorry I can't present tomorrow because it's too unpredictable. So I'll have to do a talk next year, but I'm hopefully going to be able to make it to that small amount of the panel session. I'll see if somebody can cover for me for a few minutes. So
awesome.
Yeah, I'm looking forward to it.
All right. I'm looking forward to tomorrow. Thank you for inviting me here this evening. And again, we have a shared goal: prevent stillbirth, do everything we can to have healthy babies. So, and moms, of course.
Yeah, exactly. We want to get parents and babies home safe together.
Exactly. All right. I'm going to say good night, everybody.
All right. Thank you all so much. We're going to sign off now. See you bright and early tomorrow.